Good morning, Professor Christie, and thanks a lot for reviewing my patient's case with you. So, a 50 years old South Asian male, Mr. SS, with unremarkable medical history, who presented to our clinic yesterday with frequent attacks of nagging cough with profuse expectoration of mucopurulent sputum of 10 weeks duration. Mr. SS is a new patient to our clinic who was just seen for his first visit yesterday. According to Mr. SS, initially cough was present during winter only and persisted for about 2 to 3 months. For the last 10 weeks, it is present throughout day and night and is more marked and hackier in the morning with whitish to yellowish thickened phlegm. Other associated symptoms are generalized chest tightness during and after coughing spells and shortness of breath, which is progressively getting worse. He described his coughing as lingering and nagging, which interrupts him from his sleep and from doing the simple conversation at times during daytime. Mr. SS also stated he often needs to clear his throat to get rid of sputum. He quantified his sputum production to about half a cup per 24 hours. Mr. SS also reported that his coughing spells settles down after expectorating and rest and gets aggravated with moderate to severe exertion, especially at work where he is exposed to dust. He reported he was seen for similar symptoms previously at his primary care physician office in January of 2019 and May of 2018. Both times he was diagnosed with acute bronchitis and was treated with Ventolin, amoxicillin, and a short-course oral steroid taper. The management did improve his symptoms, but his productive coughing is on and off since January of 2019, for which he never paid attention until it got worse 10 weeks ago with increased thickened sputum production. He was using honey and ginger tea, throat lozenges, and Robitussin at home with temporary relief. The pertinent negatives during brief review of systems were absence of fever, sore throat, facial pain, headache, runny nose, nasal congestion, night sweats, hemoptysis, weight gain or weight loss, paroxysmal nocturnal dyspnea, palpitations, nausea, vomiting, and constant or intermittent chest pain in the absence of coughing spells. In terms of allergies, he denied any known allergies to medicine or food, but reported being allergic to pollen and pets, although with no history of anaphylaxis in the past. His past medical history is unremarkable except for GERD, which is well controlled as per patient with over-the-counter antacids. He had appendectomy at the age of 10 years and wisdom tooth removal in 2000. Patient's mother is in a good health and father has COPD. His immunizations are up to date with the last influenza vaccination in December of 2018. Mr. SS was mostly in his usual state of good health until 10 weeks ago. He uses over-the-counter Centrum's multivitamin for men once daily and takes Pepto-Bismol on a PRN basis for heartburn. In terms of social history, Mr. SS smokes a pack of cigarettes every day and has a 20-pack years history and has not thought about quitting as of yet. He denied alcohol and illicit drug use. He is married in a monogamous relationship and has 2 healthy children aged 20 months and 5 years. He is employed as a construction laborer for past 10 years and is more than often exposed to dust, fumes, and air pollutants. He denied any recent travel outside of Canada and any recent contact with sick people. During physical examination, he generally appeared well but had on and off coughing spells during conversation, causing him to stop mid-sentence. He coughed up about a tablespoonful white tenacious phlegm during his conversation with me. His oral temperature was 36.8, heart rate was 112 and brisk, respiratory rate was 24, blood pressure of 124/82, and body mass index 25. Respiratory assessment revealed the lateral diameter of thorax to be greater than the AP diameter. There was no tracheal deviation observed during inspection and palpation. Thorax was symmetrical with good chest expansion. Diaphragms decentered 4 cm bilaterally. He had soft and low-pitched vesicular breath sounds over most of the lungs except bronchovesicular and bronchial sounds over the large bronchi and trachea respectively. Scattered coarse crackles were heard in early inspiration and expiration. Rhonchi and expiratory wheezes heard as well, but most of these sounds were cleared after patient expectorated the phlegm out. Percussion notes in ladder pattern were resonant with an area of dullness to the left of sternum from the 3rd to 5th ICS and area of liver dullness in the right 5th ICS in MCL. Tactile fremitus and transmitted voice sounds were normal as well. Pulmonary function test demonstrated reduced FEV1 over FVC ratio of 70%. No finger clubbing and edema in lower extremities noted, neither do peripheral or central cyanosis. Use of accessory respiratory muscles noted right after coughing spells, which settle down after resting for some time. There was no evidence of subcutaneous emphysema as evident by lack of crackly tactility under the skin. Gastrointestinal wise, bowel sounds were present, time 4 quadrants, no bruise or pulsatile mass detected. Examination of the nose and throat was unremarkable. No rhinorrhea, nasal mucosa was pink with midline nasal septum, no sinus tenderness during palpation, and no exudates noted during oropharyngeal examination. There were no signs of lymphadenopathy at cervical and supraclavicular area. Cardiac assessment revealed no heaves, thrills, regular apical pulse with no murmurs, rubs, or gallops. The JVP was 3 centimeters above the sternal angle with the head of the bed elevated to 30 degrees. Carotid upstrokes were brisk without bruise. The PMI was tapping 1 centimeter lateral to the MCL and 5th ICS. S1 and S2 were crisp. S2 was louder than S1 at the base with physiologic split A2 greater than P2. S1 was louder than S2 at the apex. So, in summary, Mr. SS presented to our clinic with 10-week history of chronic productive coughing with thick tenacious phlegm production, which is more pronounced in the morning. He had almost similar symptoms in the past times 2. At the time, he was treated with bronchodilators, empiric antibiotics, and steroids. His associated symptoms are progressively worsening shortness of breath, interfering with activities of his daily living, and generalized chest pain, most likely non-cardiac. The aggravating factor, as reported by Mr. SS, were exertion and exposure to dust, and alleviating factors were expectoration and rest. The pertinent positive for Mr. SS are 20-year tobacco pack history, family history of COPD, and continual exposure to dust and air pollutants at his front jaw. The physical examination revealed tachypnea, tachycardia, frequent coughing spells with a tablespoonful of white tenacious phlegm production, use of accessory respiratory muscles post-coughing spells, adventitious sounds upon auscultation which cleared upon after coughing the phlegm out, and reduced FEV1 over FVC ratio. His current presentation suggested chronic bronchitis, but other differential diagnosis of asthma and bronchiectasis needs to be ruled out with further diagnostic imaging follow-up. Thanks again, Professor Christie, for providing me the time to present my patient's case to you. Thanks.